Hello friends, today we are going to discuss about the tumor lysis syndrome. This was the also theory question which was asked in DRNB critical care exam in April 2023. So we'll have the discussion on this. So what is tumor lysis syndrome? Tumor lysis syndrome refers to the state of deranged metabolic state which is characterized by hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, azotemia, which is secondary to the rapid breakdown of the tumors. It is life-threatening oncological emergency. So it is very important to identify the patient who are at high risk, and it is also important to start the early preventive measures to prevent this condition. So let's see what is pathophysiology behind it. So rapid cell breakdown results into the release of intracellular ions like potassium, phosphorus, uric acid, and this which is causing the overwhelming renal excretion. So delayed recognition of these metabolic disturbances can lead to acute renal failure, cardiac arrhythmias, and seizure. So cell lysis can be spontaneous and it typically follows chemotherapy. So this is the diagrammatic representation of the pathophysiology. So first there is a lysis of the cell which causes the release of the DNA, which releases the purine. Then this is converting into hypoxanthine. Because of the xanthine oxidate, it is converting into xanthine uric acid. And then if urate oxidase, which is not available into the human, it is the uric acid cannot be converted into allotropin. So basically what I want to say is when there is a excessive lysis of the cell, then few electrolytes are there which are present inside the cell. That is getting released into the blood. And if it is released into the large quantity, then that leads into the renal failure. And because of this excess electrolytes, that also is also responsible for the irritation in the form of cardiac arrhythmia and seizure. So what is etiology behind it? So lymphoproliferative disorders with the rapidly multiplying malignant cells, including acute lymphoblastic leukemia, Burkitt's lymphoma, they are more prone for the tumor lysis syndrome. And it is uncommon in solid tumors like Wilms syndrome, retinoblastoma, but not unknown, particularly with the usage of high effective therapies. So patients with the compromised baseline renal function are more prone than those with the normal kidney function. And why we should worry more about the tumor lysis syndrome? Because of the mortality rate. Mortality rate is up to 20%. So the definition of the tumor lysis syndrome is based on the lab feature and the clinical features. So lab features include. So the criteria for the lab feature is as follows. If two or more of the following metabolic abnormalities are present within 3 days before or up to 7 days following initiation of therapy, then we can label it as tumor lysis syndrome. Now we'll see what is it. Normal range for age in children. If the phosphate levels are more than 4.5 mg per dl in adult and 6.5 mg per dl in children, if potassium levels are more than 6, and if the corrected calcium is less than 7 or ionized calcium is less than 1.1. Now we will see the clinical characteristic of the TLS. So the presence of lab TLS and the abnormalities in any of the following end organs, like kidneys, that is acute kidney injury, increase in serum creatinine of 3, or any single value of 1.5 times the upper limit of normal for age in the absence of baseline value, and oliguria lasting for 6 hours. Then cardiac arrhythmia, death, and neurological seizure. So the for label it as TLS, there should be either lab criteria which are satisfying the tumor lysis syndrome, or clinical criteria should be present which leads to the which satisfy the criteria which are there for the tumor lysis syndrome. Okay. Now we'll see what are the clinical features. So before going for the clinical features, it is very important to know which patients are more predisposing for this condition. So if we know the type of the tumor, we can predict whether this patient has a probability of going into tumor lysis syndrome or not. So high risk tumors are Burkitt lymphoma, leukemia, lymphoblastic lymphoma, acute lymphoblastic leukemia with the TLC count of more than 1 lakh, acute myeloid leukemia with the TLC of more than 50,000. Then intermediate risk tumors are acute lymphoblastic leukemia with the TLC of 50,000 to 1 lakh, acute myeloid leukemia with the TLC of 20,000 to 50,000, then the diffuse large B cell lymphoma. And few tumors are of the low risk, like hepatoblastoma, neuroblastoma, Wilms tumor, germ cell tumor. If these tumors are there, that means there are very low chances of proceeding into the tumor lysis syndrome. Now, it is also important to know what are the predisposing factors for the tumor lysis syndrome, so that we can understand, we can gauge that this patient might land up into the tumor lysis. So it is very important to know the characteristic of the tumor. That is malignancy, which are prone for the rapid lysis. So the patient who receives the high chemosensitivity and who have the rapid growth rate. For example, acute leukemia, non-Hodgkin lymphoma, and large tumor volume like a massive intra-abdominal tumor, bone marrow involvement plus hyperleukocytosis, or extramedullary disease like huge lymphadenopathy and massive hepatosplenomegaly. Then host characteristics. If a small child with large tumor, or any volume depleted state like poor oral intake and GI losses. Then aggravating factors like co-administration of nephrotoxic drugs like vancomycin, amikacin, amphotericin, and contrast agent, and the tumor which are infiltrating kidneys like leukemia, lymphoma, or the tumor which are obstructing the ureter. And few are the few highly effective chemotherapy, like someone is receiving rituximab in non-Hodgkin's lymphoma. So in majority of the patient, early stage of the TLS will be asymptomatic. So we should identify this stage, and so we should identify the patient who are at high risk, and we should at least initiate preventive measures so that patient won't go into the end organ damage. So the typical manifestation may occur after 12 to 72 hours after initiation of the chemotherapy. Rarely onset will be spontaneous. So the patient can present with the significant hyperkalemia, that is potassium level of more than 7, which lead to the ECG changes, including peak T wave, QRS complex widening, which is unrelated, may result into the ventricular dysrhythmia and death. Sometimes patient will present as hyperphosphatemia, and which is manifesting as cardiac arrhythmia, tetany, seizure, because of the hypokalemia. So the metabolic trash can overwhelm the renal excretion, which results into the renal failure. So at this stage, the patient may become oliguric or unuric. So rarely, patient can present initial presentation can be hypertension or acute renal failure, which leads to the acute leukemia. Unattended TLS will rapid progress. Unattended TLS will be rapidly progress, and it can result into the death. Now we'll see what is the management. So management is the early identification of the high-risk patient, hyperhydration, management of the specific electrolyte imbalances, role of alkalinization, and renal replacement therapy. So let's see the first, which is early identification of the high-risk patient. Tumor lysis syndrome is best managed by early anticipating and preventing measures than treating the higher than treating this established TLS. So the patient with underlying predisposing factor, we need to monitor urine output very aggressively. Not only urine output, but we should keep the eye on the electrolytes every, like sodium, potassium, calcium, phosphorus, uric acid, and creatinine every 6 to 8 hours during initial 48 to 72 hours of chemotherapy. Then we need to go for the vigorous hydration and administration of prophylactic allopurinol, which plays a key role in the prevention. Continuous ECG monitoring is useful as electrolyte imbalance is rapid. And if we think the patient is really at a high risk, then we should involve the nephrologist earlier and we should keep the very low threshold for dialysis. So, first step is hyperhydration. So, vigorous intravenous hydration is the cornerstone of prevention as well as treatment of the TX. So, the guidelines are give the hydration with the saline dextrose fluid at the rate of 2 to 4 times of the maintenance. And the target for the urine output should be 2 to 3 ml per kg per hour. That means if the patient is of 60 kg, then the output should be 120 to 180 ml per hour. Then fluid should be started 48 hours prior and continued at least 48 to 72 hours following initiation of chemotherapy. Then fluid should be potassium and calcium free. If the urine output is below 2 ml per kg per hour, or if the patient is in volume repleted state, we can add furosemide at 0.5 mg per kg per dose every 8 to 12 hours. Then try to maintain the HB of more than 7. Transfuse only if the HB is less than 5 to avoid fluid overload. Then how to manage the specific electrodes. The patient can present with the hyperkalemia, so which is defined as serum potassium level of more than 6 MEq per liter. So similar management is the similar to the any other cause. Like monitor ECG continuously, perform electrolytes every 4 to 6 hours. Then cardiac membrane stabilization is achieved by 10% calcium gluconate. So we can initiate the intracellular shifting of the potassium ion by giving 0.0 ml per kg of insulin, 2 ml per kg of 25% dextrose over 30 minutes by giving salbutamol nebulization and soda bicarb infusion at 1 to 2 MEq per kg IV push. Then furosemide along with hydration increases urinary potassium excretion. Exchange raising eliminate potassium through bowel and gradually decrease the serum level. Then emergence of hyperkalemia is itself is an indication to initiate dialysis, particularly if above listed measure fail to lower the levels. Now next is how to manage hyperphosphatemia and hypoglycemia. So hyperphosphatemia is defined as serum phosphate concentration of more than 6.5 and serum calcium of less than 7. So hyperphosphatemia can result in cardiac arrhythmias and nephrocalcinosis. So how to reduce this serum potassium phosphate? It is reduced by hydration with most effective hydration, which is most effective measure. Then we can give insulin with hypertonic dextrose. Then oral phosphate binders like aluminum hydroxide and cevilamide. Dialysis, then we should go for dialysis if all other measures are failed. Then increase in serum phosphate is accompanied by the decrease in the calcium. So hypocalcemia is manifested as muscle cramp, tetany, seizure, prolonged QT interval, and fatal dysentery. Any measure to increase serum calcium will increase the calcium phosphate product, leading to the metastatic calcification. So calcium supplementation is reserved only for symptomatic patient at lowest possible dose, that is 50 to 100 mg per kg slow infusion under cardiac monitoring to relieve the symptoms. Now the next electrolyte abnormality is hyperuresia. It is defined as uric acid of more than 8 mg per dl in adult or above upper limit of normal range of age in children. So how to reduce this hyperuricemia? So we can administer allopurinol, which is xanthine oxidase inhibitor, and we can hydrate the patient at least 48 hours before and continued this hydration for at least 72 hours post initiation chemotherapy. So this allopurinol is administered in the dose of 10 mg per kg per day in 3 divided doses, and maximum dose is 100 mg per day. The dose is reduced to 50% or more in renal failure. So allopurinol prevents the formation of additional uric acid, and it, however, does not lower the level of pre-existing raised uric acid. Then establishment or high propensity to develop clinical disease. Then we can administer drasburicase, which is a recombinant urate oxidase, and it can be used for both prevention and the treatment of hyperuricemia. And the dose is zero point 0.05 to zero point 0.2 mg per kg per day IV infusion over 30 minutes. So it acts by converting uric acid to the allantoin, which is inactive product. So rapid reduction in the uric acid level without accumulation of the precursor product is possible. And the availability of the rasburicase is significantly reduced the need for the dialysis. However, rasburicase is contraindicated in J6PD deficiency patients. So we should, before administering rasburicase, we should check the J6PD levels. If the drug is expensive, the single dose often suffices in the clinical practice, and it can be repeated after 24 hours. Then the next is role of alkalinization. So uric acid is soluble at physiological pH. The systemic alkalinization is performed previously with the administration of 25 to 50 milliequivalent of sodium bicarbonate to 50 ml of maintenance fluid to achieve the urine pH in the range of 6.5 to 7.5. But because of the urine alkalinization, there is increase in the uric acid solubility. And the potential problems are aggravation of symptomatic hypocalcemia, obstructive uropathy due to intratubular calcium phosphate precipitation in alkalinized urine. Then the crystallization of the uric acid precursor, that is hypoxanthine xanthine at alkaline pH. Therefore, alkalinization has pros and cons, and it is a subject of the controversy. So, alkalinization is not performed routinely. It may be considered in patients with hyperuricemia, with rasburicase cannot be administered due to financial constraints. Now, our last option is renal replacement therapy. Despite above measure for prevention and treatment of TLS, few children may develop renal failure or refractory metabolic abnormalities. So dialysis is the effective and rapidly reduces the load of metabolic product and maintain the U volume. Continuous renal replacement therapy is preferred modality in patients with hypotension, large metabolic burden, and volume overload state. In resource limiting setting, we can go for peritoneal diagnosis. Prognosis for recovery is recurrent is excellent if we admit if renal replacement therapy if we start initially. However, it must be emphasized that dialysis is suboptimal option compared to the prevention of acute kidney injury. So rather than going for the dialysis, it's very important to prevent this acute kidney injury. So this is the summary of our management of tumor lysis syndrome. So for diagnosis of tumor lysis syndrome, we need to obtain serum potassium, calcium, phosphorus, uric acid, creat level, and baseline ECG. And it is also important to monitor the urine output. If any of the if any two of the lab parameters are abnormal, then assess the end organ damage, whether there is a acute kidney injury, whether the patient is presenting with seizure or arrhythmia. So if the answer of this question is yes, then the patient is having clinical disease. So at this stage, involve the nephrologist as early as possible. Start with rasburicase for hyperuricemia. If needed, go for the renal replacement therapy. And manage the electrolytes and urine. But if there is there is no evidence of any end organ damage, Then we can label this patient as lab TLS, laboratory TLS, and we can start with the treatment line as hyperhydration plus furosemide, administered allopurinol. Try to maintain urine output of more than 2 ml per kg per hour, electrolyte and renal function monitoring, and specific measures for hyperkalemia if present. Then reassess at 6 hours. Improving electrolytes and urine output maintain, and if the urine output is maintained, then reassess the patient after 24 hours. Then role of the chemotherapy. If the patient who are at high risk of TLS, chemotherapeutic agents are often administered in phase manner or so as to prevent this massive tumor lysis. Thank you guys.